Hopefully it doesn't go further, but in that 70 to 80 range. So right now we have 85 active acute infections, with 32 of those in the ICU and 13 on the ventilator.
It's a pretty high equilibrium.
Yeah, we would certainly like to get back down to the 30s or the teens or none. We do have 41 patients who meet that recovery period but are still in the hospital because of COVID. In Hayes, though, they do have 30 patients, 27 active and 3 in that recovery period too. So it is taking up a large proportion of their hospital beds.
And that's true throughout the state. As we can see, the Kansas map is on fire, and so is Missouri, and all of us are being affected so much right now by COVID that we are having to do all sorts of things. Open up alternative care areas, take some of our post-anesthesia recovery areas and turn them into hospital beds for patients to be in. We just don't have enough beds. We're opening up more ICUs. I mean, we're in the midst of that crisis, and we're a little encouraged by the fact that yesterday and for 2 days in a row, Kansas City's numbers didn't go up as much, and our numbers didn't go up as much. But we also know that could just be a testing issue. There could be a lot of things that could cause a short pause, and Thanksgiving is right around the corner. The fear of Thanksgiving is a lot of people inside will spread the virus, and that'll be another super spreader event. And that could be really devastating to the community right now. So be really thoughtful around that, especially because there is such good news out there. And we've been short on good news. Yeah. We've been trying to latch out to little things, Hawk, about trying to say that we'll take that as good news, or we'll take this. But this vaccine thing, on top of the monoclonal antibody, that's very real. So really good news coming out of Pfizer today.
Yeah, absolutely. We have 2 now with Pfizer and Moderna, so I think it is very, we are optimistic because of that. Certainly, we know that this is safe. All of the data points to that, but now we have the efficacy data as well for 2. So I think moving forward, and we know that with Operation Warp Speed, there was resources put in with the government and the companies to help start to increase those vaccine production lines so that we can get them out to as many people as quick as possible.
Yeah, and I think that's really important. So the timeline for Pfizer's with that data, they're going to, I think as I understood, they're going to submit their EUA within days. And they hope that if that gets turned around, it may be, weeks before the vaccine's out here, meaning like before Christmas. That's like the best Christmas present to everyone. And it'll be lined out, it'll be sent out to those in wave 1A, which we understood to be frontline healthcare workers, as well as those most vulnerable, like patients in nursing homes. And then it just keeps moving through beyond that. And I think that we're, I'm sure you and I are going to line up and get these vaccines. And I think we got an influenza shot on this program. I bet we're going to have to get I think we're going to have to get this vaccine somewhere like that. So that'll be good, and it's good to be able to deliver that kind of really good news, because it's been a difficult long haul. Today we have Anil Garmaker, one of our long haul patients, speaking of long hauls, and his doctor, Sharon Kraft. They're going to help answer questions about what that long haul has been like. Anil's been with us before. We're delighted to have him back in just a moment. And we're going to listen to them. But first, let's see what questions are out there from reporters.
Hey, good morning. Cody Holyoke, Channel 9.
Hey, Cody.
How are you guys doing today?
Good.
With the positive vaccine news today and over the past week, do you think people will be more willing to listen to your warnings that you've been saying for months, and, from health officials, if they know potential relief is on a horizon? I'm just curious your take on that.
Good. Bless you for asking that question, because I've been following that line of analysis now. Every time we get to talk to an elected official and saying at every moment that we can, real hope is here. It's not that interminable hope that means you're going to have to keep making these sacrifices for so long. If you go back to last May, when Francis Collins, who's the head of NIH, was involved with one of our board meetings, he told us he thought by the end of October, first part of November, we'd have vaccination, and that would be a game changer. Fauci has said the same thing. He said by this time next year, life's going to feel a lot more toward normal. I think that's where we're headed, and we just need people to still be good, to help us get to the other side. So yes, I'm hopeful that this news will work to convince people of that. We've been certainly using that as a lever to say to those who are in elected officials, public health officials here and across our region, say, look, really good news, really effective therapy that will help us change how we live is on the way. In the meantime, the most important things you can do to stay alive and help us keep patients alive is to follow the rules of infection control that we've been preaching for months. And I think it's all about the mask. It's all about social distancing. It's all about staying in your bubble. It's all about those small groups that you can stay with. Anytime you start intersecting groups, the likelihood is that someone will have COVID-19. What's the number you have to get 40 or 50% now, Hawk? For a mixing of a group of people, if you went out to a group of 10 or a group of 20 folks.
Last week it was if you had 15 people at your gathering, there was a 40% chance that at least one person in that gathering would have it. If it goes up to 25, it's just above that, and 50 people, it's more than 60% chance. And again, that was last week.
And so it's going to be even higher now. Yeah. So just think about that. If you had 15 people, if you knew somebody in that group had COVID-19, would you still get together?
Yeah.
If you knew they did. But that's the real choice you have. You narrow it down to a small group, you wear a mask, things get a whole lot safer when that happens, because masking does work. And as the weather turns cold, go prove it to yourself. Go outside, see what your breath cloud looks like, put your mask on, and see what your breath cloud looks like. It's altogether different, huh?
Yeah, absolutely true. But we still, and it's not the people that are watching the update and the nightly news. It's the people that aren't watching that. There is still a backlash for mask wearing and people being demeaned for wearing a mask. And it's backward thinking. It's not keeping up with the science, and it's not even complicated science. It's just not wanting to acknowledge what is really going on, what is the true reality. But we know those things can save lives. And we know from our guests, you can have just a meeting of 4 people, and one can be infected. So the more people you have that do not live in your household, in mixing households, the more risk you're going to have of even just one of those people having a disease.
Yeah, remember the rules. We the people, not I the one. You don't have total individual liberty.
No.
It's spelled out in the preamble to the Constitution. Other questions?
Brian Johnson with Channel 9 asked, school districts have seen an intense contrast in the speed that COVID-19 has spread over the last week. They now have in-class transmission of the virus and 50% sub-placement rates, running out of substitute teachers. Mm-hmm. What caused such a dramatic change in the last week? Is it the post-Halloween gatherings, increased temperatures related, or something else?
And the answer to that, I think, Hawk, is going to be yes.
Yeah.
Anytime you're in a group of people with the masks off, you're going to be in trouble. And I think that we're seeing that around schools, but especially not the classrooms, perhaps, as much as even outside the classrooms. However, I know David was talking about, and maybe you know more about this than I do, there are early signals out there that suggest opening of schools, and schools may be bigger spreading events than we thought. But I think, again, it's still the gatherings, it's a socialization around the school, it's the hallways, it's the parties afterwards, and I think sports, and especially indoor sporting events, are trouble.
Yeah, I think the classrooms really they've done everything to make them as safe as possible with dedensifying, with the masking. But we know that overall, young people, whether it's 40 and under or whether it's 18 and under, young people are getting together and spreading it in the community and bringing it into the schools or whatever businesses they are. We know that people who have done everything right and tried to stay out of those situations get the disease because there is such widespread community infection right now.
Yeah, and I think that in one school may not be the next school, meaning that some districts have done a really good job at dedensifying, going hybrid schedules, things like that. Others have not. And so we can't treat all schools the same. Those that have not had effective masking policies or dedensifying a campus and have more people in the classroom, maybe the 6-foot rule, maybe the hallways aren't as well patrolled, whatever. Those things make a difference, and so I don't think it should be a surprise to us. We saw that in colleges. Colleges did a really good job of infection prevention control, have been able to stay open, and others have had to shift to more online learning. I think KU has done a really good job. I know other schools have had to start closing their campuses early, and it shouldn't surprise any of us. It's all about the rules, right? And the virus doesn't care who you think you are. It just doesn't care. And anytime you give it the opportunity to spread, that's what the viruses do. That's what makes measles so deadly. That makes what other viruses so bad. But I think that I think that's the real reason. So I'm not surprised that we're seeing that rise in schools. And just to say, the Pfizer and Moderna vaccines at a 95% effective rate, that's as good as measles, Hawk. That's really, really, really good. That's much better than the influenza vaccine.
Yeah, much better than the influenza vaccine.
Brian has another question. He says some epidemiologists say any new restrictive measures that fall short of a total lockdown will only plateau the number of cases in our area. He wants to know if you agree. I know it's a tough question.
He said, no, I'm going to be really honest. You know, as the numbers rise in Kansas City, I get more and more concerned that a total lockdown may be a direction we're going to have to go. And my direction looking at that is very much in my lane. I can't address the pain that small business owners or any business owner has, and mental and emotional health. Because that's real. What I can tell you is that we're out of beds in Kansas City, and if the numbers continue at the current rise, we will overwhelm our healthcare community. And then it's not just the COVID-19 patients we can't take care of. If you have a heart attack or a stroke, or you need emergency surgery and there's no beds, we're going to struggle. And so the death rate and the morbidity rate, meaning how you don't do as well, from all diseases, not just COVID, goes up, and that's what we're going to feel. And so I'm very concerned that if folks don't help us bend the curve, then we're going to get forced, at least from a healthcare perspective, in saying we can't take care of this many patients. If we can't take care of people who are sick, that they're going to die, and that means heart attacks, strokes, cancer. Name heart failure, people who are having trouble with their asthma, their emphysema. If we can't take care of people, then that's going to really affect everyone. It's not only going to affect those who don't wear masks. And so I think that the struggle is that we are all in it together. And we just urge everybody to, whether your county has a masking requirement in your area or not, just try to exercise personal responsibility to try and wear a mask and follow the rules, because we can bend the curve. If we can cap right now at 85 or 90 and then vaccine becomes available, okay, let's get there. We're pushing things off right now that we shouldn't be, we don't want to be pushing off. But I don't want to say that we can manage. It needs to be lower, but higher is going to be really, really, really hard for all of the health systems in Kansas City. All of us are in this same boat. It's not just KU. It's all of us. And you hear that from our chief medical officer all the time. And tomorrow we'll have a little bit of that conversation. Mark Steele, the CMO over Truman, will be on, and he can add that. And we'll have our CMOs back soon. But when you do, you're going to hear it. It's from all of us. It's a chorus. It's not a solo.
All right, last call for reporter questions before we move on.
All right, I'm not hearing anything. You may recall the story of Neil Garmaker. He was one of our patients who contracted COVID-19 back in April. And Neil was on a ventilator for a time. He's been in and out of the hospital, and because he's had some airway complications, that his physician, who is also with us today, and we're glad that she's back on, because Shannon, your thing dropped off, so now Shannon Kraft is an ear, nose, and throat physician here at K, is back on. Delighted to have you with us, Shannon. Thanks for being here. We're going to talk a little bit about what it's like to be a long hauler and what are some of the things that they've had to go through. So Neil, tell us a little bit about where you are in your life. I know you just had another procedure, you're back in town again. How are you feeling? How are things going for you?
Well, my vocal cords are a little angry at me from yesterday, but I think we're kind of, I think Dr. Kraft said we're improving a little bit. We're kind of just on a wait and see. Still have shortness of breath, still have a little trouble breathing at times. I know some fatigue, but other than that, I'm glad to not be in the hospital again for the last 3 months. I consider that a success.
Yeah, that's a victory. I mean, you've really had a tough road on the recovery from this, and congratulations to you for having done as I know you've worked so darn hard at this as an ICU physician. I spent years doing this kind of stuff, and have watched people do that and see them back in clinic. You've had that hard road, and talk to us a little bit about what is it like mentally and emotionally, the toll being a long hauler has taken on you and your family.
Honestly, I think it's been harder on my wife than it's been on me. Before the trach, we were in and out of the hospital almost every other day. My wife wouldn't sleep at night. She would stay up while I was sleeping because she was afraid I wouldn't wake her up if I stopped breathing. So she would wait till I was up to sleep. I mean, it was definitely, it took a toll. It was, it was day by day. I know the last time on the way to the ICU, my wife was watching mile markers and where we were at from Wichita to Kansas City because she didn't think I'd make it all the way this time. She was waiting to see where she'd have to call for help. And I know that trauma from day one, from April until now, I really feel it was worse on her. I mean, it was dramatic on me, don't get me wrong, but I feel much worse about how it affected her and the people closest to me.
Neil, what do you say to people out there who still want to be deniers of how bad COVID-19 is, or call it influenza, or don't want to wear a mask?
I figured this question was coming, so I thought about it for a bit, and I'll be much more transparent than I've been in the past. Before I contacted it, and it's ridiculous and inexcusable, when I had a friend that was a critical care nurse in New York City when I got sick, and I heard what was going on there. And I firmly believed that as healthy as I was, I wouldn't get it. It wouldn't affect me. I even told my wife it wouldn't be that serious if I got it. I didn't think it would be in our region. It was a big city problem. It was a problem for people seriously ill or elderly. And, even when my mom dropped me off at the ER, as a nurse, she didn't use PPE to drop me off for the 20-minute drive. And because of that day at home and that drive, my last thought before the ventilator was, oh my God, I've killed my family. And, COVID didn't care what I believed, it was there and it was waiting, and I gave lip service to being careful, and I could have been more careful, and I wish I would have been. But, and thank God, COVID didn't care what I believed, and thank God everyone at KU, when I got there, they didn't care either. And they fought like hell, and it took an inordinate amount of labor and man hours and doctors and nurses to keep me alive and get me back, even up till now. And I just, it scares me if enough people show up that need as much care as I needed to stay alive, if there will be enough services to keep them there or for people to recover.
I'll never be able to say it better than you just did. Thank you. Shannon, first of all, what a special patient you've got here.
Yes, sir. Absolutely. He's been a fantastic patient.
Talk to us a little bit about some of the battles that Anil's had to face and some that you've seen in other COVID-19 patients.
Absolutely. So I should start by saying that what Mr. Garmaker is experiencing is not unique to COVID, but because COVID causes significant respiratory distress, patients require ventilation. And so the injury that has happened here is because of the need for ventilation. We know from the data out of China that approximately 10 to 15% of people will have sufficient disease to require intubation. And the same disease processes, the same medical comorbidities that make you prone to having a more severe course with COVID are more likely, are also associated with a higher incidence of intubation-related trauma. And so I'm very grateful that Anil has allowed me to kind of talk a little bit about what's going on with his throat. And so for those of you out there in the community that don't have experience with intubation, I brought a little prop today. This is an endotracheal tube. This is what goes into someone's throat when we need to help them breathe. Now, we intubate hundreds of patients a day here for surgeries, and it's not a big deal. But when you have a critically ill patient with other medical comorbidities, this tube that sits between your vocal cords can actually put pressure on those cords and cause inflammation. As it turns out, the cartilage that supports our throat, our larynx, and our voice box is very sensitive to that pressure, and it can compromise the blood flow. For this reason, patients who have diabetes, obese patients, patients with cardiovascular disease, for whom it is more difficult to ventilate or who have impaired perfusion or blood flow to these areas, the addition of this little balloon in the throat when it blows up to create the seal can shut down that blood flow for a period of time. And what this results in then is that cartilage becoming sick and inflamed and starting to collapse. Mr. Garmaker is my first patient with COVID, but he is unfortunately not my only patient who has had laryngotracheal injury secondary to intubation due to their time in the ICU. And these are complicated problems to fix. These often require multiple surgeries. Many patients who have to actually have to have a tracheotomy to support their airway. And I think one of the most disappointing things, and particularly from a patient's perspective, is when you leave the ICU after a long bout with a respiratory illness and you think that things are going well. This creeps up. It creeps up on you 2 to 3 months after the intubation many times, and then you find yourself dealing with a whole host of other problems. So as we see more and more people being intubated, we anticipate that we're going to be seeing more and more people with these types of injuries requiring surgery and even tracheostomy to manage.
Yeah, this is a tough time, and because there are so many people with injuries like this, you're going to be really busy. This is kind of your area of ear, nose, and throat, so
yes, sir.
I suspect you'd like to be a little less busy on this one.
Yes, sir. You never want to put a trach in someone unless you have to. It's a great tool. It's a very useful tool. But, our goal for Mr. Garmaker is to continue to work on expanding his airway and trying to get that bigger, and the hope is to be able to get that out someday.
All right. And Shannon, don't make me feel old. Quit saying sir.
It's a habit. Sorry.
I have the same one. All right. Let's see what questions we have, Jill.
All right. Stephanie wants to know, when the doctor says we are out of beds in KC, do you mean KU or in the entire metro area?
So we're running out of beds. I can't talk to about every single hospital. I just know that we have now developed a report that shows the number of staffed beds available in Kansas City, and those are showing few beds. And so we are running out of beds in the entire metropolitan area, all things if you put them all together. And so what's going on at KU is a reflection of what's going on across. We're all trying to find more staff to help work beds and to get more physical beds. But I think, we are running out of beds. And again, that's the same message we gave last week to the public health officers and to the elected officials. It's what we said on Friday afternoon when we had a press conference with reporters and others, because we're trying to get a message across that folks have to take this seriously. And Neil gave you the best personal testimony of anyone that you'll ever hear about how serious it is. We're telling you, we don't have a lot of beds. You got to follow the rules. If you don't follow the rules, things are going to get worse. And if they're going to get worse, they're not only going to affect the people with COVID-19. Every disease is affected when we don't have enough beds.
Cindy wants to know, will Anil ever get off his ventilator?
Well, I think what she's trying to say probably is are you ever going to get off that trach, Anil? And let's talk to you and Shannon and see where that's going to go for you.
I know Shannon's or Dr. Kraft is hopeful, but to be honest, I think there's a lot of unknowns. And she was very clear to me that, it's a possibility we may not.
And so just so the public knows, that little whistle you hear each time Anil takes a breath is the air going through his trach. And so that's what we're listening to, because really as he takes a breath, the air is going in and out of his trach and less so in and out of your mouth, I think, right now. Is that right, Anil?
Oh, yeah, that's correct. Especially after the surgery, everything's a little mad at me this morning.
All right. Shannon, what do you think? How will Anil do, and how do people like him fare in the long run?
So it really depends upon where the injury is. And so I do have to say, sorry, Neil, I was the one that beat him up just a little bit yesterday, but we are working on trying to get that airway bigger. There are multiple levels where one of these tubes can cause an injury. One is at the level of the vocal cords, one is at the level right below the vocal cords, and one is the trachea itself. When things get really complicated is when the injury involves multiple levels. When the injury is involving just a trachea itself, this can often be addressed by a surgery known as a tracheal resection, where we take out the abnormal portion of the trachea and sew things back together. And when I do this, I work with Dr. Nirmalveer Makashaneni, who helps me with those particular surgeries. When the injury is higher, when it's right below the vocal cords involving the vocal cords, it becomes more complicated because that is not a static structure, it's dynamic. The vocal cords hinge open and closed, and that is actually the narrowest part of the adult airway. And so for Anil, we have been, after we put his trach in to secure his airway to give him a safe way to breathe, we have been working on local steroid injections and dilations to try to open that up. Right now, the trach that you see in his neck it's underneath the area of swelling, and so we basically bypassed the narrow area to provide him a safe way to breathe. Our hope is we can get that area above the trach big enough that we'll be able to pull the trach out someday. If we are not successful in doing this with endoscopic procedures, then we may have to pursue a bigger surgery in the future. But those carry their own risks and complications, and the same medical conditions that put you at higher risk for having the stenosis also make you a higher risk for poor outcomes with those surgeries. So we do try conservative things first. There's some progress for Neil. He's able to do some capping, and so I'm optimistic. We're going to try some things here in the near future to see, to kind of test things out a little bit and see how close we are.
All right, well, good luck, and good luck to you both.
Celia with the Kansas News Service has joined the call. She said she was late, and she has a couple of questions. Celia, are you there?
Yes, I am. Can you hear me?
We can, Celia. How are you?
I'm fine. And Anil, it's great to see you again, and I hope you're well and that your family's well. I was wondering, so for people who go through, what Anil is going through now and might, get COVID now and need ventilation now, what do we know about whether in Kansas there are enough of the supplies for ventilators and the ventilators themselves and I don't know if respiratory, physician or what is the right term, but the specialized physicians that we need for them?
You bet. So, and Hawk, you can comment on this as well. I think right now, because we do have more ventilators, we've all been able to purchase more ventilators, I don't think we have a shortage of ventilators. Right. The other thing is that because of things like remdesivir and steroids and Lovenox, there are more people. The ratio, I think, help me with this, Hawk. Yeah. The ratio between the people in hospital beds and the people in ventilators is a little better than it was early in it, when as a whole bunch of folks were. If you're in the hospital, a lot of them went to the ICU. We don't have as many going to the ICU, so I think we're a little better off than that. Now, as far as ICU docs like me, we're always in short supply.
Right.
We're always. That's also the problem. But the real problem is it's ICU nurses, it's respiratory therapists, and that's just because there aren't enough beds and floor nurses. That's where the real shortage is. And so we call those staff beds. Do you have the resources to run a lot of beds? And so do you have a lot of telemetry? And there was a couple of hospitals I've talked to that said, man, we just don't have another bed with telemetry, which means monitoring abilities. And so the hospitals were not built with the idea that we're going to get overwhelmed by a pandemic like this. And I think there was also been more hope that people would be a little more responsible around stuff. So
I think to your point, we have a third of our patients right now that are in the ICU that are on the ventilator. So there's a 60% that are not. I think we are actually kind of having some trouble, or in the near future will, with those high flow nasal cannulas. So not necessarily the ventilator, but another mechanism of delivering a large amount of oxygen to somebody without putting them on the ventilator. But just as you said, and I talked about this yesterday a little bit, a lot of people that enjoy football, a lot of people aren't as lucky as we are to have Patrick Mahomes. They're saying, to win, we need a quarterback. Well, if you ask the coaches, you can't just go out and pick up a quarterback. It's the same thing for this, whether it's the respiratory therapists that are specialized and trained, whether it's the ICU nurses, whether it's the floor nurses, whether it's the physicians, or whether it's the teachers. We're seeing a lot of teachers are out now, whether it's full-time or substitute, because it's just hard to go out and fill in those gaps that are now occurring because of quarantine or actual infection. So it's really the staffing seems to be more of a problem than the actual mechanical ventilators themselves.
Yeah, I think we're going to run short. I think we're going to run short on staffing and physical beds before the ventilator question, and but the staffing is what's going to drive the shortage as much as anything. Shannon, are you feeling any different down in the ENT area from what you're seeing around that?
I'm sorry.
As far
in
as the
terms of staffing,
shortages,
sir?
yeah. Well, staffing, but also just the shortage of equipment and things. Have you seen any?
Yes. So one of the, early on, particularly in China, a number of ENT physicians, and in England as well, got ill because we work where the virus lives. We work in the nose, the nasopharynx, and the upper airway. So we've been very fortunate to have great leadership with Dr. Chu, who was very early to kind of step up our game in terms of acquiring sufficient PPE, but also employing protocols. The biggest change I think that we have currently is that because we do have these safety protocols in place, and specifically we have to let rooms set for so long after we perform scopes, which is part of our almost everyday practice. That does decrease the volume of patients that we can see in person because those rooms have to be processed differently, and that equipment does have to be processed adequately before we can see additional patients. So it does create a bit of a backlog, and that's been the biggest issue for us.
Other questions?
Any more questions?
Yeah, I was wondering then, so for Anil, if he continues to need a trach long term, and I know it's already been months, but if it's going to be years, what are the health issues involved with that, and how often might he need to go to KU Health for follow-up procedures or checks?
Shannon, thoughts?
Yes, so I do have many patients with trachs for many different reasons. If we are not successful in getting the tracheostomy out of Anil, it is possible to live a long, full life with a tracheostomy. I think I lost the sound there. But those patients do have some limitations. You'll never swim again. That's a direct conduit into your airway. You have to make changes in the way that you take a shower. It really does have, more than anything, a huge impact on your quality of life. So while it is the thing that allows you to breathe and to live life, it changes the way. In terms of follow-up, if this ends up being a long-term trach for Mr. Garmaker, typically I will see patients every 3 to 4 months for routine trach care and to make sure that the trach is healthy.
All right. And Anil, you must have thought about that in your life. What do you think?
It's definitely been an adjustment. I know the first time I took a shower, I tried to drown myself, but I've gotten better with time on how we handle that. I definitely needed some help from my wife keeping it clean. It's as much as it's an adjustment in that way, I still appreciated more than anything being able to get air again. Didn't realize how bad it was until I could get air. I mean, I would obviously love to be back close to where I was before, but if this is as far as we get, it a little farther, I'm still happy there.
Good luck with that. Any other questions, ma'am?
So Anil, have you been able to, I'm gathering that this continues then to disrupt your life in terms of ability to work as well and other parts of your life?
Yeah, I've definitely had to scale back how much I was working, if much at all. There's been times I've needed to take breaks, or, I have to be careful what environments I'm in, because not only water, but dust, oil, grease, anything is kind of a direct conduit, as Dr. Kraft put, straight to my lungs. Right now, while I'm still recovering for the most part, we've also, I think I call it a firewall. We've increased our firewall in the house because while I'm recovering and with everything we're doing, it's definitely scares us, not so much to get COVID, but we're being extremely careful not to have any extra contact with anyone that might have a flu or cold or anything that might slow things down more than where we're in the trajectory we're going.
All right.
All right. Other questions, Jill?
Yeah. Melissa wants to know, can you speak to the level of seriousness at Hayes Med, knowing that their bed capacity is
Yeah, we're in pretty regular contact, and maybe we can arrange for a discussion soon with Heather, who can join us, the Chief Medical Officer there at Hayes. But I think they, like all of us, are struggling with trying to figure out, how do I take care of our routine patients, as well as how do I take care of all these people with COVID, and seeing the numbers go up and being concerned about what's going on around them. You have to remember, Hayes isn't going to only be taking people from Ellis County. It's all the counties around there. It's it's really one of the last bastions of more of a referral hospital as you go west. And so for central western Kansas, places like Hayes and Salina and Garden City, those are really important. And I think that Dodge City, and I think is what we see happening, is that those counties all have really high and rising rates of COVID-19. And so that is going to affect their ability to deliver care. And then they're trying to look to transfer the sickest of the sick to other places. And it's all just filling up. So the stories in Kansas City are being replayed. We had a meeting this morning with physicians throughout this and providers throughout the state, and I think the message is still the same. We're having a harder time bringing people into Kansas City. Everybody's having a harder time transferring patients, and it's all because the beds are full. And so we're really at that place we were most afraid of right from the start.
Tammy says that she tested positive for COVID. Symptoms were normal: everyday cold, bad headache, slight chest burning. She said that she was told, once you get it, you're immune, and she would not have to quarantine a second time. She goes, she doesn't understand why we would have to quarantine.
That's not good, Hawk. That's probably not the right information.
No, absolutely not. We know that reinfection can occur. We don't know what happens when you get reinfection. Some people have had no symptoms. Some people have had worse symptoms. We also don't understand exactly, can you transmit the virus to other people? The theory, the thought is, yes, you can still transmit the virus to other people, even with reinfection. We just don't know the full answer to that question. So, after you get the virus, after you had the first round of disease, you continue to have to use those pillars that we've talked about: masking, not meeting in large groups, distancing, all those things in an effort to protect yourself from getting it again and the possibility of spreading it to others again.
Ryan wants to know, are the monoclonal antibody infusions being used in the emergency department setting for patients who are not sick enough to be admitted, or only in outpatient settings?
That's a great question. We'll come to that. And so what do you think, Hawk?
I think it depends on what health system and where you're at. A lot of the emergency departments, unfortunately, around the nation are filled up with patients. They don't have the space to be able to do that. We are working on a separate site to be able to do that, an infusion site, so that you can go and do it as an outpatient infusion there, not the emergency department, because we know how full our hospital and our emergency department is.
But you might, if you're not going to be admitted, you might be able to redirect it to the infusion site.
Absolutely.
Because the key is you have to get it within 7 or 10 days on the monoclonal antibody infusion. The other thing is, right now there's so many people that need it, and there's a limited supply of the monoclonal antibodies. As that supply gets better, we'll also we'll also all be in better shape. So have we infused anybody yet, or is that coming this week?
It is coming this week. Yes, we haven't yet. We are still waiting on some final protocols and IT kind of things. But really, the physical space is set up. We're just waiting on some of the I's to be dotted and T's to be crossed.
So, I think we were all surprised by the speed in which this actually came to us. It was a lot more rapid, which just tells you folks were ready. I think this is going to be the story of the vaccine. I think it's going to just appear on our doorstep one day. Hey, by the way, here's the vaccine. And by the way, it's minus 70. Are you ready? Because I think it's going to feel a little like this, because this is sort of how remdesivir just sort of appeared one day. Yeah. I think this has appeared one day, and I think it's just everybody's working so hard to try and get it out there. Last question.
Yeah, and we do have a lot of vaccine questions, which I'm saving to tomorrow, because we have vaccine experts on, which you're going to talk about in a second. But tons of people are asking about indoor sports this fall and about singing in church, because apparently, according to the thread, some of that is happening. And they just wonder, what do you think about those two activities?
I come back to this, and it sounds a little repetitious. Those of you who've been with us for a while will know what we're going to say. It's all about the rules of infection control. Can you sing in church? Probably not. Not really. Not safely. Now, if you got 20 or 30 feet between you and the next person and you're wearing a mask, okay, you probably can. But is that really how it's being carried out? I think indoor sports are going to be a problem. First of all, the room turnover rate in most gyms is really not very fast. And I think that just means we're going to run into trouble with that area. And so that's a concern. The second concern, meaning when I say room turnover rate, the air is in that gym, the virus will sit there, and I just am not convinced how fast some of those buildings are able to get to bring in fresh air. The second thing is people tend to scream and shout. And the third thing is they may not be wearing a mask. And fourth thing is people don't always follow those rules of social distancing inside a gymnasium. I think that the fans are more at risk maybe than even the kids. I do think the kids are at risk too. But when you put a lot of fans together like that, plus they're an older generation, then I think that's a problem, Hawk.
Yeah, absolutely. I know some of the sports entities and leagues are having only one or two parents there. But just as you said, when it's outdoors, football, soccer, whatever that may be, baseball, and there's cheering, that's outdoors. You can probably separate a lot better. But we know parents are going to cheer. And when that happens in an indoor space, just as you said, with the air turnover and maybe lack of turbulent airflow, it's just going to be at higher risk of spreading the disease.
All right. So before we turn to our final comments today, I just want to remind our listeners that tomorrow we're going to update the AstraZeneca Phase 3 trial. That'll be great news. We'll be live with a mobile van that is also going to go some of the harder hit areas of the community and talk about how we're enrolling folks for the vaccine trials in those communities. Dr. Mario Castro, who is the Med Center here, is a division director for pulmonary and head of our clinical trials unit. He's going to be back along with Dr. Barbara Pahoud, who is from Children's Mercy, and Mark Steele, the executive chief clinical officer at Truman. All are going to be focused on the AstraZeneca vaccine trials, but really just vaccination in general. So tomorrow we'll be having a long conversation about vaccines. I think that's going to be great. We look really forward to that. Dr. Kraft, final thoughts this morning.
As you go out into the world, just be safe, wear your mask, wash your hands, and be nice to one another. It's trying times for everyone, and we appreciate that, and we appreciate that folks are fatiguing, and know that everyone here at the hospital is doing their best to make sure that we can take care of all the folks in the Kansas City community and their medical needs.
You bet. Hawkeye, final thoughts?
I think everybody, go back and retweet or re-listen or send out Anil's comments. Those are the most striking thing. These aren't just numbers of people being infected and dying. These are individual people that are our friends, people that we love. Anil exemplifies that more than anybody. And just retweet that, listen to it, get it out there, because it can happen to anyone.
Neil, I love to give hugs, and I wish I could give you and your wife a hug right now. And that's I'm a hugging doctor. I hug my patients, and I think they're really important. I'd like to hug all the researchers out there who are helping get this vaccine, the monoclonal antibodies, give the folks at Pfizer and Moderna and all the ones who have worked with them a big hug, because it will make a difference for us. And so, Neil, why don't you sign us off today? Tell us your final thoughts.
Toward the hospital, I know my girls were very excited to finally get to meet Dr. Kraft, even if just see her on screen, since with all the protocols, they haven't been able to see her. And for her and her team, I just want to let you know how much we appreciate everything. How much you guys reached out to us and how compassionate you guys have been. Even if it was just someone touching a foot, in a really hard time, everything was noticed, and we do appreciate it. And,
Thanks.
I don't think he's part of your team, but he might be Will in the RT. I think he's been the most amazing respiratory therapist we've ever, experienced in ICU. And, my girls, my family, we just want to thank you and everyone.
Absolutely. It's been our pleasure. And please tell your girls I said hi. And even if this is only how we get to meet, you've got a great dad, guys. Take good care of him.
Thank you. Thank you.
Is this really any different from a bad flu season? And my answer was easy. That's one of the easier questions that I've been asked lately. We never have 2 ICUs or 3 ICUs full of intubated influenza patients. Even in the worst of the years, H1N1, for example, wasn't like this. This is not the flu.
We made our mark in this program by not flapjacking. We don't flap our arms and jack with the truth. We try and be calm and tell you the truth. And today we did. This is the truth.
I would actually then say to everyone watching, I would actually implore you now to take another step and say it is now time for each of us individually to be more aggressive in how we follow the rules of infection prevention and control, more aggressive in how we pare down our bubble size.
We have to take care of each other. This is a character issue. We're going to take care of each other, or are we going to say that our individual decision to not wear a mask and to go out to party and do different things trumps we the people?